My name is Corisha. I am the physician liaison here at Pediatric Specialists of Virginia. It is so nice to meet with you all again. We are so excited to continue our Catch Your Breath series with Dr. Martin. We will be speaking today on outpatient reactive airway disease. So please feel free to take many notes and, save all questions for the end. We want to make sure that we address everyone, and we are going to get started.
Perfect. Thank you.
You're very, very welcome.
Right.
Thank you.
Perfect. I will go ahead and get this projected. It's your screen. All right, everyone can see the slides?
Yes.
Okay. All right, guys. Well, good afternoon. Thank you for letting me talk about I think one of my strongest passions is young asthma, as I would like to call it. In this presentation, we're going to talk about the diagnosis of asthma in children under 5, the problems with it, what are some things that we can do to better find and define what asthma is in young children, and also talk about the problems of diagnosing someone with recurrent bronchiolitis and reactive airway disease. All right, so no disclosures, and I'll probably be zipping through these slides because that's something I'm very passionate about. I have lots of things to talk about. So, like I said before, we're going to discuss about the terms reactive airway disease and recurrent bronchiolitis in kids, the epidemiology and patterns of wheeze in children 4 years and younger, diagnosis of asthma in young children, and the management of these children with recurrent wheezing. So this is a scenario that I get pretty often. It's children under 5 who come to my clinic for chronic cough with or without wheezing. He has this cough most days of the week, even when he's well. It occurs in the morning, and it especially occurs at night. They've had this history of being diagnosed with bronchiolitis or bronchitis. Sometimes they get prescribed albuterol with these, and which seems to help, but they still have this issue where they give them the albuterol, and overall the cough frequency still isn't improving, although the albuterol does help at least calming the cough in the moment. They have some eczema. There's some family history of asthma as well. Mom was told that the child has reactive airway disease as they're too young to have asthma. So the questions I have for today is, do we agree with this diagnosis of reactive airway disease? Is this patient, in fact, too young to have asthma? What are the chances that the child will continue to have symptoms when he's older, and how would you treat this patient? So as someone who gets their fair share of med students and residents coming through the clinic, and this is often one of the most common patients I see in clinic, these are the things I usually hear from them, that they're too young to have asthma. They have to wait until they're 4, 5, 6, 7, 8, 10 years old to be diagnosed. They have to have spirometry to diagnose asthma. It's reactive airway disease. They have a history of recurrent bronchiolitis. And I would say that all these statements are either false or they're just not really helpful when managing these kids. And so there's, again, this idea that you have to wait to a certain age to have asthma. And I always just kind of think it's funny because I imagine this kid who's like previously healthy, doing extremely well, and then he's at his birthday, he's 5 years old, he blows out the candles, and then he has bronchospasms and starts coughing. And now, whoa, we have asthma, we're 5. Get the inhaler out. And I like to point out the fact that this kid actually should be using a spacer for his inhaler. But we all know that it's kind of ridiculous that these kids that come and see me, they don't just turn 5 and they have asthma. They have this history of coughing that's pretty persistent, dry, maybe some wheezing as well. So this starts well before the age of 5. But it is fair to say that wheezing is more prevalent, at least when it comes to emergency visits, in young children. And in fact, that this kind of 0 to 4 age group is predominantly the largest age group that contributes to ED visits for wheeze. So wheezing the first 3 years of life, it can actually portend to some more persistent wheezing later on. I kind of draw these from Martinez, who did the Arizona Tucson cohort following kids with wheezing, and what he saw is that 1/3 of babies with a history of at least one episode of at least one episode of wheezing in their first 2 years of life. So we already have this big group of patients who have wheeze and thus are at risk of having a second episode of wheezing. And then up to 40% of babies with this history of wheezing with viral infection before 3 years of age will still have recurrent wheeze by the time they hit school age. And so these terms I hear that are synonymous with asthma are reactive airway disease and recurrent bronchiolitis. So I've always tried to find where this term reactive airway disease came from. I really can't find anything in literature about what this specifically has to do with childhood asthma. Reactive airway disease is actually more of something that is more related to occupational asthma. So basically, if someone was exposed to some kind of dust or inhalant during the workplace and that causes acute bronchospasm, that is more related to what true reactive airway disease is. But from how I've seen it applied to kids is that this is kind of an unspecific catch-all term for symptoms of cough, wheezing, and sputum production, invariably seen in children less than 5. Doesn't tell us in any way, shape, or form how often or severe these symptoms are, but coincidentally, its treatment for exacerbations, albuterol steroids, are incredibly similar to that of asthma. And then we have recurrent bronchiolitis. And again, it's not impossible for patients to have bronchiolitis more than once. All right, but bronchiolitis is a more specific term of just obstruction due to kind of cellular debris and inflammation in the airways. Asthma is, again, it's more the reversible airway obstruction that can be triggered by recurrent infections. I usually get suspicious of asthma in patients who have multiple hospitalizations or ED visits for bronchiolitis. They have wheezing in between colds, they're over 2 years old, or they have a family history of asthma or other risk factors for asthma, such as prematurity or atopy. And this is where the AAP bronchiolitis guidelines comes into play. And I think these guidelines are great. I think they're science-based. The issue I take with the AAP bronchiolitis guidelines is that I feel they're kind of used inappropriately in a lot of situations. And basically, the biggest situation that I kind of see happening is that they're applied to children who don't really fit the AAP bronchiolitis guidelines. And they actually have a paragraph that nicely summarizes which children should not be part of these guidelines. And these are children with underlying respiratory illnesses, such as recurrent wheezing, chronic nasal lung disease, neuromuscular disease, cystic fibrosis, and when we otherwise rule out heart disease as well. But again, the bronchiolitis guidelines, first-time wheezer, great. You can apply them. Don't give a trial of albuterol because it hasn't shown to be helpful. But that second time they're admitted to the hospital or you see them in the emergency room, they no longer fit in the bronchiolitis guidelines. I beg everyone, please allow someone to give this kid albuterol just to see what happens. And again, trying to further define what asthma is, this is the kind of a rather long-winded definition from the National Heart and Blood and Lung Institute, but when you break it down, it's really a chronic inflammatory disorder characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and cough. As seen in susceptible individuals, we'll talk about what these individuals are and what characteristics make them up, that have variable airflow obstruction that is reversible spontaneously or with treatment. And they have this bronchial hyperresponsiveness, this airway smooth muscle contraction to a variety of stimuli. What's important to note in this definition, there's no age cutoffs. There's no definition of what spirometry findings define asthma. So, does it really matter what we call recurrent wheeze in children less than 5 years old? And I kind of want to take this from George Carlin, who's one of my favorite comedians, in that he brought up this idea of having a soft language, where basically we take terms that are very descriptive and kind of blunt, and then we progressively kind of stretch those terms out, soften those terms just to kind of protect ourselves and protect the patients that we're taking care of. And I think with one of the reasons why we're afraid of diagnosing asthma, and it's something that I've kind of picked up from asking people why we are diagnosing reactive airway disease of asthma, is that with asthma, we have this fear that we're going to place a child on medication, such as an inhaled steroid, that they may not need. We don't want to expose this child to medication side effects. Asthma is considered a lifelong condition, and that it may affect future occupation prospects. So we don't want to give them that label if it's not true. And it's understandable, but we see that empirical treatments are pretty common in pediatrics. We prescribe antibiotics for ear infections, pneumonia, sore throat, even though we know that most of these are going to be caused by viral etiologies, and antibiotics aren't really needed. We do trials of H2 blockers for reflux, even though we don't send every kid to GI to get reflux studies. We prescribe antihistamines for allergies before we refer them to allergy to get skin tested. And it seems like we're pretty comfortable with treating these other conditions with medications that do have side effects. But for asthma, it seems like there is a general kind of tendency to be conservative and really not try any inhaled steroids or controller medications prior to getting a firm diagnosis of asthma, which is pretty hard in kids under 5. But let's talk more about the safety of your inhaled steroids. It's kind of a reason why there's a hesitation to start them in kids. They're generally both well tolerated. When it comes to albuterol, we've seen kids in the hospital tolerate days of high-dose continuous albuterol without significant issue except for tachycardia. When it comes to inhaled steroids, I always hear about this concern for growth. And while, yes, there has been studies that have shown decreased growth velocities when it comes to daily use of inhaled steroids, it's not a sure thing. Studies have been conflicting on results. And when it comes to the severity of this growth velocity, it's really always seen studies up to maybe a centimeter decrease in final adult height. As for that centimeter, there's some families who find that centimeter very important to keep. But generally, overall, uncontrolled asthma isn't really great for growth either, which is why I tell parents that even though this patient may be a centimeter shorter than what they're supposed to be, generally they'll be just as tall, their parents are even taller. The other thing we worry about with steroids is adrenal suppression. And in laboratory studies, there is evidence of adrenal suppression, but when it comes to how clinically significant this adrenal suppression is, we really don't find any strong evidence that it causes significant issues when it comes to immune function or growth or anything else related to the adrenal system. Asthma, unlike the Supreme Court, it's not a lifelong commitment. We see that in other cohorts of asthma that there are several patterns of wheezing in these patients. So this is the Avon longitudinal study over in England that followed patients with wheezing, and they kind of found several patterns of wheezing. So you have these kids at the bottom here that don't wheeze early on. Some will develop wheezing when they first get into school, maybe just because they're exposed to more viruses, but it becomes more persistent over time. There's some patients who don't wheeze who don't really develop recurrent wheezing until even later on in life. Then you have patients who do wheeze early on. Some of these kids will have maybe wheeze once or twice and never go to wheeze on ever again in their life. You have other kids that have it during preschool, but then grow out of their asthma. Then you have other patients who wheeze frequently, often, starting at the very beginning of life and then continue on for the rest of their life. But again, this pattern, this table shows that just because you diagnose someone with asthma due to recurrent wheezing doesn't mean that they're going to have recurrent wheezing for the rest of their life. And just because someone doesn't have wheezing early on in life doesn't mean that they can't have symptoms show up later in life, be diagnosed with asthma later. This is just another slide from Martinez's cohort in Tucson, which shows what kind of risk factors are seen with which type of pattern of wheezing. And really, eczema, rhinitis, apart from colds, asthma, they're all very strong risk factors for asthma. Maternal smoking is especially strong for kids who wheeze early on, but then don't wheeze later on in life. For eczema, what's really interesting is that it's seen more often in these early wheezers rather than patients with no wheezing, but not so much in kids who develop wheezing later on in life, but certainly more so in patients who persistently wheeze. And I think the last thing we worry about too is that when we diagnose with someone with asthma early on, there's a chance that if they ever want to go into the armed forces, that this will be a disqualifying condition. However, if this patient does have asthma early on, his or her symptoms resolve, and I think about joining armed forces later, you can definitely just refer them to our clinic. We can do some methylcholine challenges, rule out asthma completely, and then they can certainly show that to their recruiter, and it'll be fine. We do have patients who don't have symptoms really significantly in teenage years, but they come in and do spirometry. We actually see pretty significant lower airway obstruction, at which point it actually probably was a good thing that we caught them and are able to tell them that maybe our forces isn't the best thing for you, before they actually go back to their Army recruiter and actually get enrolled in the Army. I think the one other thing I want to stress is that these ill-defined diagnoses are not helpful. Reactive airway disease, it's not something that's very descriptive. If I hear mild persistent asthma, mild intermittent asthma, severe persistent asthma, I can kind of already have an idea of where to kind of go with this patient. With reactive airway disease, it's pretty ambiguous, and so is recurrent bronchiolitis, just because it could be due to multiple things. The thing about asthma, we have great guidelines available, like we talked about previously, GINA, and an asthma education prevention program here in the U.S. With reactive airway disease, we don't have any guidelines. For recurrent bronchiolitis, we don't have any guidelines. So is anyone with recurrent wheeze having asthma? And the answer is no. But when it comes to populations at a high risk for asthma, these are the patients that obviously we worry about the most. We should especially be worried about asthma in kids who have recurrent wheeze and evidence of chronic inflammation. Patients that have personal or family risk factors for asthma that show response to albuterol and have wheezing apart from colds. Other things that can cause recurrent wheezing, several things: foreign bodies, CF, PCD, bronchomalacia. These, while numerous, are much less common in patients than asthma is. So this is what it really comes down to: is like, okay, we have this kid, he's wheezy. Which ones do we treat? So again, we look for the kids first who have chronic inflammation, the atopic triad, asthma, allergies, eczema. They do run together, and it's pretty significant how closely they're related. So 71% of children with eczema will either have allergic rhinitis or asthma. Almost half of kids with allergic rhinitis will have exercise-induced bronchoconstriction. And children with allergic rhinitis are 3 times more likely to have asthma. That's why it's so important to ask about these conditions in young children when we're thinking about maybe starting them on some kind of inhaled steroid or not. Eczema and allergies are criteria for majority of childhood asthma prediction models. If you do happen to get a CBC on these kids, which can happen in the hospital, if you do see an elevated serum eosinophils greater than 4% or elevated IgE levels, that again is more supportive of chronic inflammation, and in a patient with recurrent wheezing is more supportive of asthma. Going back to this idea of susceptible individuals, obviously any kind of family history of asthma is important, especially a maternal history of asthma. Smoking, big risk factor, especially in utero. And then out of the womb, smoke exposure, preterm delivery, allergies, all risk factors to develop asthma. Reversible airflow obstruction. So it'd be nice if we can get spirometry on these kids and show definitively that they have airflow obstruction that responds to albuterol. However, kids a lot of times can't do spirometries under the age of 5. I hear a lot that, oh, we tried albuterol and it didn't get any better. Well, yeah, sometimes they have a pretty bad exacerbation. One albuterol treatment is not going to do it. I mean, that's why we have these kids admitted and they're on continuous albuterol. So if this is your kid that's coming in for their second, third, fourth episode of wheezing, and you try one albuterol treatment and it doesn't resolve the wheeze all the way, I would just try another one and see if that helps. The other thing that we need to look for in these kids is, do we have obvious stimuli that triggers their symptoms? So kind of usual stuff for asthma, inhales, irritants, scents, colds, swings in temperature, exercise, allergies, or even just like laughing or horsing around. The asthma predictive index, this is another tool that can be used to help clinicians figure out whether this kid is with wheezing is more prone to develop asthma or not. Basically, the criteria is that for the stringent, what we call the stringent index, are kids who have 3 or more episodes of wheezing in the first 3 years of life and have either 1 major or 2 minor criteria, which is the major asthma in a parent or eczema in a child, mild, and the minor criteria is either rhinitis, wheezing apart from colds, or peripheral eosinophilia greater than or equal to 4%. You can use this index for patients who have maybe 1 or 2 episodes of wheezing, although it's what we call using the index loosely. And obviously, it's not going to be as specific as if you were using a child who has more recurrent wheezing. And this is what the kind of the positive predictive and negative predictive values of those indexes are. What you can see as for a person who has do not meet the criteria for positive asthma predictive index, the negative predictive value is 93.9%. In someone who doesn't meet the asthma predictive index criteria and are used stringently, it's 91.6% negative predictive value. So again, I think these predictive indexes are more useful when they're negative. Positive predictive value, loosely, 26.2%, more stringently, 47.5%. So not as great. I really like this kind of thought process by the GINA guidelines in 2022 to look at probability of asthma. I think it's a little bit simpler, and it's something I've kind of made sure to apply into my visits. But basically, just looking at symptom patterns. So for patients who have cough, wheezing, heavy breathing for greater than 10 days with colds, have more than 3 episodes per year, have episodes in between colds, those are kids that are likely to have asthma, and you're more likely to have good response if you treat them with asthma medications. Spirometry, not that great in young children. Vast majority of children, even if they have asthma, have normal spirometry. About half of them, when they're under 6, can perform spirometry. So that leaves a lot of patients who are unable to perform spirometry correctly, and we can't get good information from. Sorry, kind of scroll through here. Asthma severity, that kind of changed where you kind of used to this kind of table from the National Blood and Lung Institute with our based on symptoms. Now it's kind of more retrospectively applied, where we consider you have a patient with asthma, you try them on medications, and then you kind of define their severity, which I think makes a little more sense. So patients who just need maybe some smart therapy or a low dose inhaled steroid with albuterol have mild. Patients who are in step 3 to step 4 treatments, moderate patients who require higher doses, combo inhalers, or more significant treatments to have severe. We talked about this previously, but just to kind of give you a short review, at least from the latest NAEPP guidelines for patients under 4, for viral wheezers who only have viral wheezing maybe a few times a year, you can do high doses of inhaled steroids with albuterol. Otherwise, your kind of go-to is to start an inhaled steroid with just regular albuterol, and then higher up, you may consider adding these combo inhalers. One thing I would like to point out, especially that maybe we didn't talk about last time, is the use of montelukast. it's a rarely preferred treatment. The benefits of montelukast just don't really outweigh the side effects, the possible side effects of montelukast. So only in step 3, when you're trying to maybe prevent them from needing to go to a combo inhaler, can you consider doing a low dose inhaled steroid and montelukast? Otherwise, montelukast is always a alternative medication. We talked about these last time. Nebulizers versus meter dose inhalers, equally effective. I would say whatever the child will keep on their face is the best option. So you start treatment. What do? Follow up in 1 to 3 months. If improved, you can continue medication, or you can consider weaning or titrating them off the medication. If there's no significant improvement, then you can always consider some other evaluations for other diagnoses. So to summarize, asthma can be diagnosed at any age. You don't have to be 5. You can be any age. Reactive airway disease and recurrent bronchiolitis, I kind of wish that we phase those terms out as descriptors for patients with recurrent wheezing, as they're not very helpful. Patients who wheeze early on in life, a good proportion of them will have recurrent wheezing later on in life. The important thing is identifying wheezers that have a higher risk of asthma, so high risk of chronic inflammation, have personal or family risk factors for asthma, or evidence of allergic inflammation. When it comes to management, for just patients who are viral wheezers only, 4 years and under, you consider high-dose inhaled steroids. For patients 4 years on step 3 and 4, you can consider smart therapy, but really probably just like a combination, ICS, LABA daily, and albuterol is needed. Montelukast is rarely preferred. Please don't start them unless you really have to. And then otherwise, when it comes to nebulizers or inhalers, doesn't matter. To me, it's just whatever family a patient prefers. Those are my references, and I'm looking forward to any questions you guys may have.
Thank you very much, Dr. Martin. This is very helpful. So just to follow up on that MDI inhaler versus nebulizer, so no preference at all, irrespective of age, correct?
I do not have any, no preference. I know there's this idea that in younger babies, the nebulizers deposit better in the lungs. Really, the studies have shown that that's not the case. What really is important is whatever they'll keep on their face and be calm in taking. If they're screaming, you have a lot of more turbulent airflow in your central airway, which inhibits deposition in the lower airways. So whatever they'll keep on their face, whichever they'll be more calm in taking, I think, and whichever is easier for parents to apply, that's the modality I would prefer. I would say that with albuterol, the one benefit that you have with a nebulizer is that there's a little bit of saline in it. So if they are particularly congested, it can help break that up. But then you have to kind of balance that with the increased risk of side effects, tremors, hyperactivity, agitation that come along with it. Also the problems with transportation and electricity that they need to be used with.
And would you use the spacer with the mask for the first 5 years and then mouthpiece after 5, or there is no?
I would definitely, for me, I really wait until they're about 7 years old.
Oh, okay.
To switch to mouthpiece, unless they do spirometry and they just seem very mature for their age and can do the maneuvers. For me, at 5 years old, even though I've seen that kind of be the cutoff for masks versus mouthpiece, I think from what my experience is, it's pretty hit or miss, as some kids will be able to do the mouthpiece correctly. So I usually stick with the mask until they're about 7 or 8 years old, and I've had better success transitioning to a mouthpiece spacer.
Thank you very much.
Of course.
And I know we talked about that last time, so no benefit for peak flow meters, right?
Yeah, so with peak flow meters, one thing I see is that on spirometry, patients that have a completely normal peak flow and still pretty mild to moderate lower airway obstruction. And plus, with it being so effort-based, I just don't see a lot of value in it. You have to have someone who is able to do it consistently, That's going to be an issue in younger patients and older patients and teenagers. I worry about their effort in doing it. I've really only seen one patient that it really worked well for, and that was a 17-year-old with such severe persistent asthma that he would come to the PICU and he could tell the PICU attending when he needs to be intubated. And so we would kind of follow his peak flow scores every day. And if we see a trend, he's like, oh yeah, put the tube in me. But generally, I don't use it in practice. I don't think a lot of my colleagues use it in my practice either.
Thank you so much.
Of course.
This is Lisa Kelly. I have a lot of patients who don't want to use a spacer.
Yep.
And at what I try to explain to them how to do it, and I never am sure of how successful that really is.
Yeah.
Do you have a strong opinion on that?
I do recommend spacers. You just have better lower airway deposition with spacers. What I tell patients that if you put the inhaler directly in your mouth and you spray it, it's going to hit to kind of just hit the back of the throat and stick there and not get to the lowers as much as it should. My kind of analogy is that if you're riding a bike full speed down a hill and there's a wall at the bottom of the hill, it's trying to take this corner at 90 miles per hour versus with a spacer, it'll slow that rate of inhalation down and take that corner at 5 miles per hour. A lot of patients seem to that seems to click with a lot of them. Yeah, I do endorse spacers, but yeah, I hear your point. And I see it often that patients are like, oh no, I just stick in my mouth and it works just fine. And I do the best I can to tell them, please don't do that. Use a spacer. Even as adults, we have to use spacers as well.
Okay. Well, I'll keep trying.
I appreciate the effort.
Anyone else? Any other questions? I've also put my contact information in the chat. If you guys ever have any challenges with reaching scheduling, or if there's an urgent matter and you really would like one of your patients to see one of our specialists, please reach out to me. I'm definitely willing to help for any urgent cases that may arise, or if there's issues with getting through to scheduling or something, please let me know. Please don't give my number out to parents, please. This is for you to reach me. But I also sent my email as well. I just definitely want you guys to know that I am your contact. If you need anything, please reach out.
Thank you so much. I mean, that was really extremely helpful. So thanks again.
No, thank you so much for allowing me the opportunity to talk to you guys.
Thank you.
All right.
No
Thank
problem.
you,
Have a good
everyone.
afternoon.
Bye.
Bye.
Take care.
Bye.
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 Thank you, Dr. Martin.
No problem. You guys have a good one.
Thanks.